Caregivers, have you ever felt like nothing is going right? Well, cheer up and welcome to Dave, the Caregiver's Caregiver radio program, where you'll learn how to avoid that dreaded thing called caregiver burnout and how to survive the grieving process. Join Dave and his guests now as they share practice tips and tools that you can start using immediately to help get you through this day. Now, here's your caregiver host, Dave Nassani.
From Los Angeles and the Big Apple in New York, a big LA and Manhattan, welcome to all our listeners out there in Radioland. I'm Dave, the Caregiver's Caregiver, coming to you live globally on 16 global and audio and video platforms, from iTunes to YouTube to Spreaker to SoundCloud to Vimeo and many, many more. And I'd like to welcome you all to the show, and our broadcast is also on caregiverdave.com, and we're very proud to be voted number 2 best podcast out of the top 6 podcasts for caregivers by caring.com, and I'm sure we'll make the 2018 as well. We just have to wait for those numbers to come in. And we have an exciting interview planned for you today, very exciting, very informative. All the way from Israel, let me say it that way, we have Dr. Daniel Vorobiof, the former medical oncology director of the Sandton Oncology Center in Johannesburg, South Africa. He completed his MD at the University of Cordoba, Argentina, and Doctor of Medicine degree at the University of Pretoria, South Africa. And if that doesn't impress you enough, I've got more, but I'll save that for later. But before we get started, I want to take this moment to thank my last week's guest, Lisa Cole, a cancer survivor who's decided to get a new lease on life. And you would have enjoyed listening to that interview, Doctor. I'll let you know how you can listen to that. So you can watch or listen to that interview and all our interviews on our membership website, caregiverdave.com, or any of our other 16 global networks that I mentioned earlier. All right, enough of that. Our guest today, Dr. Vorobiof, has been working in medical oncology since 1980. He is the author of more than 100 papers published in the international peer-reviewed journals and has held numerous leadership roles with U.S. and European cancer groups. He also gives his time and expertise to Belong, answering inquiries about cancer treatment and other general cancer-related questions. Doctor, welcome to the show. I'm so excited to have you on.
Thank you, Dave. Thank you very kindly for your invitation. And let's have a good one.
Let's have a good one, yes. So, why don't you take a minute or two and introduce yourself? I like to ask my guests just who is Dr. Daniel Vorobiof and why was he put on this earth?
I must say that you did a good introduction already. My mother will be very proud of that.
Yeah, tell us what I left out. But why do you feel, what mission in life do you have that God put you here to your destiny?
Since the 80s, or the early 80s, I have been involved with cancer. I was always interested in treatment of cancer, and as you can remember, 40 years ago, the treatment of cancer was very different from what it is today.
Yes.
We had very, very few drugs, and mostly the treatment was surgery, radiation, and a few chemotherapy drugs. I was very fortunate to obtain a fellowship in the University of Pretoria, who had a medical oncology department, which was very, very well known and working together with cooperative oncology groups of the United States. So my training was really a very global training. And following that, I started doing other things, meaning branching out, and founded the first and the largest oncology center, private oncology center in Johannesburg, and the largest in South Africa. And I was the medical oncology director of the center for, and I think it was 29 years, and it was until the end of last year.
Wow.
when I retire from clinical practice. And but as they say, retired, but didn't expire. So I continue working, and I'm very involved and have been very involved in education and guidance of patients, and that's what brought me to Belong. And and research also. Again, national research in South Africa and in Europe, and being part of the American Societies of Clinical Oncology and European Society of Medical Oncology, also from the point of view of education, postgraduate, and all that. Yeah.
So
I have
sound like a very smart person.
Yeah, I have been around. Yeah.
So cancer has some specialties, and what is your medical specialty exactly, officially?
Okay. So officially, there isn't. Officially, it's medical oncology. We trained into all cancer, but I have dedicated myself mostly to breast cancer and to malignant melanoma too, because when I started in 1980 in our department, to have malignant melanoma was a death sentence, and no one of my other fellow colleagues working with me wanted to start their career in a very negative way. So I said, okay, I'll do it. And I must say that the past 5 or no, even more, 8 years have been a complete game changer in the treatment of melanoma with new drugs and all the rest. So suddenly now everybody wants to jump on the wagon and be treating patients with melanoma. But but I suffered a little bit as those years that we were so limited in helping our patients. Yeah.
Wow.
But so those are the areas that interest me the most. Although, as I said, being a medical oncologist in general, so I do have my share of experience with lung cancer and colorectal cancer and other cancers. Gastrointestinal cancers, etc. Yeah.
Yes. So, what would you say is the most common cancer that comes around to people, and why do you think they're getting that kind of cancer?
First of all, it's as you know, this program is a global program, and so we cannot talk about a specific area, geographical area. So. If we look at the whole world, probably the most common in female will be the gynecological cancers, including breast cancer and lung too. If we look at males, then it will be prostate cancer as well as other cancers, lung cancer and gastrointestinal or colorectal cancers. So we cannot just look at one cancer because it's very difficult. There are some cancers that are more prevalent in certain areas of the world and others less. So, but we need to look in a more global way, and that's why I mentioned those cancers which are more relevant. Yeah.
So we always hear that the Asian communities have lower rates of cancer. So what are some American cancers, and I assume you're going to blame the diet for that, and what are some Asian cancers? Because I assume even though they're lower, they still get cancer if they haven't Americanized their diet, right?
Yeah, the Asian cancers do get more cancers when they move to America, unfortunately, and different cancers too, because you said very well that although they keep their own diet, but not always, and there are environmental influences from this point of view. So I think breast cancer happens in both groups, in females, and but some gastrointestinal cancers are more common in Asia than in America. And from lung point of view, similar situation. They are more common in Asia than in America. Especially, there is a large group of Asian patients with lung cancer that have never smoked. And that is something that we'd like to talk a little bit more once we talk, if we are going to talk about development and treatment, because it's part and parcel of some of these things that I would like to mention, which is related to changes, genetical changes, mutations, and how that affects us.
Yeah. And I have to apologize. I think I failed to introduce my lovely co-host, Adrienne Gruberg, in the beginning of the show.
Oh.
And I think she's muted because we can't hear you, Adrienne.
Oh.
There you go.
Okay.
So you look like you had something you wanted to say or ask. Am I correct?
No.
Okay. I saw your lips moving. So, Doctor, is there a perfect place on Earth that you can imagine environmentally and diet, maybe some cannibal, not a cannibal, but some people's group that we haven't discovered yet, living in some jungle on the southern hemisphere that we may discover? Is there a place on Earth or an environment that cancer cannot grow, in your opinion?
No, there isn't, and cancer grows everywhere.
Really?
Different cancers, different circumstances, different situations. Maybe there is a prevalence of one over the other, but actually there is not such a thing that a privileged place. If it was, I wouldn't tell you either way. I will keep the secret to myself, but and I would only live there. But the truth is, there isn't such a thing, and I'm sorry to disappoint you.
So, go ahead.
Yeah.
Go ahead.
No, that's fine.
Well, I wanted to ask, was there a point in time, let's say, in 4,000 years before Christ, or during the time when China was the Chinese dynasty, or in the days of Jesus, was there any period of time that cancer was not known, or they just didn't know what to call it?
Well, how would they know what to call it?
Yeah.
Yeah, actually, cancer comes from Greek, and it was.
They knew about it.
It was. They knew very much about it, and especially it was cancer. It means it's a crab, but the point is that they can see sometimes when it affects a breast of a woman or of a man also, that it forms like a crab that is trying to eat the tissue, and that's when it is advanced, and that's how the name comes from. And so it has been described. It has been even seen in mummies, in mummified bodies in Egypt.
Interesting.
And in other places it has been found. So it has been 3,000, 4,000 years ago. The only thing is that it was not as prevalent as now, because then people life expectancy was 30 years or something like that. And as you know, although cancer can happen in youngsters, but it's mainly a disease that happens, after a certain age, which is usually around 40 or more. Still can happen in children, still can happen in adolescents, but those are the minority compared to the large majority of cancers that happen in middle age. Yeah.
Well, I understand that everyone has cancer cells in their body, right?
Yes, we do have cells that can potentially become cancerous cells. But for that to happen, the body needs or the cells in our body needs to lose some of the mechanisms that we have, the balancing mechanisms that we have, which can then allow these cancer cells to start growing without discrimination, growing without stopping. And that those mechanisms are part and parcel of what we call mutations. So we will talk about that in a moment too. So the most important thing for you, for the caregivers, is what we are doing in Belong.life. Let's call it Belong so that everybody will understand. What is Belong? Belong is actually, it's an application, first of all, and it's these days is the world's largest digital cancer patient platform. So it is a social media. And what we are doing is providing a number of tools to better cope patients, caregivers, once the patients are diagnosed, and they are after too. The beauty of this app is, number one, it's an anonymous app, so you can put whatever name and register as a user, and we don't ask any other questions. It is free, which is very important too, and it's personalized because we are talking about you, your problem, your disease, your condition, your x-rays, your blood tests, your tests. You can send us all that. We will look at it. We will guide you if you're doing the right thing or not the right thing. We will not prescribe a medication for you, but we will tell you, you will need surgery, you will need chemotherapy, you will need radiotherapy, in which order, and this and that. Or we will say to you, you have a problem, you better see your doctor and discuss what this problem is. We can help up to a certain level. So it's a guidance more to the patients and to the families of the patients, the caregivers. Someone mentioned to me, yes, it's like a GPS. You're guiding the patient what to do, where to go. I said, yes, with one difference. It's a GPS, but with soul, because we are supporting the patient, supporting the family, and giving that extra that sometimes is patients are lost a little bit in the whole system, and they do not receive that support that they deserve.
Wow.
So when they go into the application, it's like a big house with lots of rooms. And there is a room where they can ask a doctor a specialized question, where there is another room where they can talk patient to patient, where there is another room they can ask ancillary related questions, medical staff, dietitians, whatever. So there are many rooms that they are under the same application, and the patient can go and choose with whom to speak and according to the problems. For example, there is a room that's called, or a division called Ask the Oncologist, and I'm manning that. But there is another one that's called Breast Cancer, and that's for patients to ask the doctor. And I'm also manning that. And I see patients sometimes asking in breast cancer and then going and asking the same thing in Ask the Oncologist. So I can answer both sides, but sometimes they want more opinions than one, and it's fine with me, because that's correct. You need that support. That's good with us.
So these are chat rooms, right?
There is a chat room between patients, and the chat room with doctors, you can call it a chat room. Patients send us a question, and we report or we chat back but not immediately because we have
not
to
live. Okay.
It is, it takes the turnover is around 24 hours.
So I think those are called forums, right, Adrienne?
Yes.
Forums.
Adrienne does something very similar on her site, the Caregiver Space. So great minds, great Hebrew minds think alike, I think. We're going to take a break. Hold that thought. We'll be right back. Don't go away.
Okay.
One Arm, One Leg, 100 Words, Overcoming Unbelievable Hardships, is about Charlene, a stroke survivor. Back in 1996, Charlene was a healthy, normal, very active 52-year-old woman whose amazing talents resemble that of both a Martha Stewart and a Wonder Woman. But all that changed when she suffered a massive stroke that left her severely speech-impaired and paralyzed on the right side. Everyone who knows Charlene is thoroughly amazed at how she lives day by day, month by month, year by year, and with a smile on her face and hope in her heart that everything is going to be okay. Just hear what best-selling author Lynn Barrington has to say about it. If you think you have it bad, read this book. This is a beautiful, genuine story told from the heart. It's inspiring and easy to read. When you finish this book, you'll be able to look at your concerns in a new light. One Arm, One Leg, 100 Words, Overcoming Unbelievable Hardships. Available everywhere.
And we're back with Dr. Daniel Vorobiof, cancer expert, and Adrienne Gruberg from the Caregiver Space, and I'm Caregiver Dave Nassani. So we're having a great conversation here, finding about cancer and what it is and how you get it and how to get rid of it. So we just heard from Dr. Daniel about Belong, which is an amazing chat room with forums that patients can ask other patients and ask the doctors, leave messages, they get back to them, get second opinions.
What's the URL?
How do we get there, doctor? It's belong.life, is it?
Yeah, it's just going to the application, if it's iPhone or Android, and you're going to belong.life, and you can register, become a user. At the moment, we have approximately 140,000 users.
Wow.
The majority in North America, and but in England, in Australia, in Israel, in South Africa, in India. So yeah, very well spread. We have approximately 70 doctors involved, and each one, or some like myself and others, have more than one specialty, and we do more than one thing in answering questions and guidance. So we have a large capacity from that point of view.
Are the doctors also international?
Sure.
So the doctors are located
in America, in India, in other places, but the patients, the problems are universal. The problems are global. So if a patient I know it's from America and I know they need some support, and so I tell them to contact American Cancer Society, or tell them to look into centers, bigger centers that are nearby and things like that. We don't refer the patient to A or B or C place or A or B or C doctor. That's not our job.
Right.
So we don't tell them what to do, but how to navigate the system. Yeah.
Yeah, it's my husband had lung cancer, passed away almost 8 years ago. So navigating is a big deal. Yeah, there's a lot that goes with it.
Right. We know that, and we understand that. And that's the reason one of the reasons for the app. The other thing that we also can provide and we are very interested in. It's in education, and education, for example, of your caregiver, because I think that we can, I don't know, Dave, if you want to talk about that now or later, because it's something that it's extremely important. We also look at research that is possible to be done with the data that the patients are supplying, participation in surveys. We ask them questions in order to understand more about their disease and try to pull together the data and understand better their problems. But again, all depends in where in the world you are and what are your what is your culture and what is your wishes and needs and all the things that needs to be taken into consideration. Yeah. And lastly, but not least important, is the fact that we believe that clinical trials are extremely important to continue the advancement of cancer treatment. And so we also have the capacity of helping patients, guide them where they can go for to undergo specific clinical trials if they are interested.
So in that case, you do refer people.
You'll tell them. In that case, we tell them there is a clinical trial that he might be or she might be eligible for, and so that it's being run in University of Florida and also in at the same time in London University and maybe in another third or fourth place. But so the patient has to make the decisions where it's convenient or not, and then they go and obtain all the information necessary. So once again, we guide them where to, but we don't take them hand by hand and to the desk of the secretary. That's let's put it that way.
Do you also let them know about promising drugs that are available in different parts of the world that are not yet approved of in the United States?
That's very difficult because every organization, governmental organization, who is in charge of giving the registry for a specific drug, it's all, they work very much similar. So if today the FDA in America approves a drug, probably it will follow in Germany or in Australia or in Israel or in the UK within a certain period of time. So yes, there are lags of a few months or something like that, but in most of the first world, actually that is not a problem. The problem is in less developed countries, and there the number of drugs that is available is much smaller, and that is a problem. So that's why we need to adjust ourselves also to the circumstances in every place. Yeah.
I was going to ask this question later, but I might as well ask it now since we're kind of on the topic. Would you consider Mexico a third world country? Because I understand they have very top class facilities and world-renowned doctors over there doing things that are illegal in the United States, and they're getting a lot of patients going down to Mexico to take advantage of this. I mean, whole communities have risen where, hotels right across the street from the cancer centers. And there's a whole industry that is supporting this industry. And, most people go there when they're desperate, stage 4, and the doctor only gives them 6 months or a year to live. And many of them, I don't know the statistics, but enough of them are getting cured or the cancer is going away that they couldn't get help elsewhere. What do you know about any of that stuff?
I know enough to be cautious in my reply to that. So yes, in Mexico there are two huge groups. One is the conservative establishment of medical oncologists trained in the USA, trained in Europe, who do fantastic work, the same like in any good place around the globe. And then there is another group of people that, in my opinion, may take advantage of circumstances, situations, and claims certain cures, as you mentioned, which are not always proven and not always scientifically investigated. So it's very difficult to give my backing to anything of that sort. I do understand why people will do that, but I will not be subjecting any of my patients to that.
No, I understand.
Yeah.
So what are the most common questions that people ask you in these forums and in these chat rooms about their cancer? You already mentioned what kind of cancers they're talking about. What specific questions are you get the most common?
I think that the most important things are they want reassurance. They want to understand that what they are doing, what they have been recommended to them, what the plan of action is the correct one. They trust their doctors, but they want to be sure that that's the right thing for them. And which is very difficult sometimes if we don't have all the necessary information. So we ask them to actually send us more information, and we can read the reports anonymously. There is a way to scratch the names and all that, and we can do that and give them a better understanding. But I think the reassurance, it's one of the most important questions from that point of view. The second most important question, I think, it's related to the treatment and the understanding of the side effects of the different medications. Because doctors, we sometimes do not have enough time to explain to the patients all the necessary in order for them to cope better with the treatment. We say, they know you're going to lose your hair, and you're going to have nausea, and you're going to have vomiting, and or you're not having, and then suddenly you have. And so the patients become very unstable from that point of view because they don't have enough information. And if you have the information before you start your treatment, you are coping better already because you know what to expect from the treatment. You know how to handle the treatment. Sometimes I have said to the patients, you're going to have A, B, and C, and then they phone you a day later and says, listen, I'm still okay. When I am going to have those side effects that you mentioned? Sometimes I say to them, I think you are going to do well, and you don't have enough, you will not have enough side effects, and boom, that's the patient that that has all the side effects written in the book. So it's very difficult, but if we give extra time to the patients, and when I say we, it's the doctors and the medical staff, the nurses also, that they are with the patient, and we inform them beforehand, that gives them a more, a better preparation of what to expect and how to manage that situation. And so other things that they ask you, they may ask you something that they don't want to tell the doctor. They feel uncomfortable. Here they have an anonymous application. They don't have to give their name, and they can say certain things that they feel embarrassed to ask the doctor. And I do understand that. Especially that here it's a one-on-one conversation, and there is nobody else in the room. There's no wife or grandmother or whoever is with, or daughter with them in the room, and they can ask questions that otherwise they feel uncomfortable. Yeah. So that is also that also comes very common, and in the. So it could be questions from the point of view of what is my life expectancy that they don't want the wife to hear or the doctor to hear, or should I should I have continue having a sexual intercourse with my wife because I'm worried I may affect her somehow, or vice versa. So they will not mention those things in front of the other people, and sometimes they will feel embarrassed to ask the doctor. But suddenly here it opens, and they are more free in that from that point of view.
Well, and on my site, the confidentiality aspect is very important. They know that they can ask questions and say things that they wouldn't otherwise be able to. Yeah. They're protected.
Sure.
Well, let's move on to, because we're running out of time here. How have cancer diagnoses and treatments changed over the last decade? I remember a relative of mine maybe 15 years ago, she was doing this brand new cutting edge thing where they take your cancer cells and then they modify it somehow and then they re-inject it to get your immune system to target attacking it. Now I hear they're using stem cell. I don't know, what do you call it? Something to do with stem cells that is helping. Yeah, that is helping. Let us know what's the latest cutting edge stuff that's out there that's working.
There are many things. It's not just one thing. What we are moving now is from treating patients with a disease to treating patients in a more personalized way to the changes, the genomic changes that they have in their body. So these days, we can do in patients certain tests which are called genetic profiling, where we can find out what mutations the patient has and is more prevalent, and hopefully be able to treat the patient with that specific medication that can attack that mutation. That's one way of doing things. Now, we have more mutations than what we have drugs at the moment, and I hope that in the future there will be equal, so that we will have enough drugs to treat those mutations. Those are one of the things. Immunotherapy also have developed, enormously, and the strides that have been done in immunotherapy, identifying different compounds in our bodies that are involved in the immune system and how to block them or unblock them in certain circumstances, it's incredible. And from that point of view, immunotherapy has entered already the clinic, And today we can say that 20% of our patients, or maybe a quarter of the patients, are already being treated with immunotherapy. It could well be that in another 5 or 10 years, that will be 50 or 60 or 70% as the time goes by and new drugs are being developed and new understandings are happening. So immunotherapy is another major thing. You mentioned about removing certain cells and treating them outside the body and re-injecting into the body. Yes, that also is being done. And there are some patients that are very well after undergoing that treatment, which is not for everybody, but for some patients with some problems. But it still remains in the realm of investigation. Is not that area is not prime time, and it's not given to everybody. But
my cousin who had that is still alive and cancer-free after 15 years.
Yeah, well, it could well be. I don't think that it was stem cells. That was probably a bone marrow transplant, and that's probably what it was. But the point is that there are many things being done today, and the advances are greater, are quicker, are faster than ever. So there's lots to be thankful. And if a patient that was diagnosed 5 years ago, and a patient that is diagnosed now, and a patient that will be diagnosed in 5 years' time, most probably those patients will have the same disease, but will be treated differently as we progress. Yeah. So plenty of new things.
Adrienne?
Yeah, are there any particular cancers that are being treated with immunotherapy more successfully than others?
Yeah, colorectal cancers, some colorectal cancer, not all of them, some lung cancers, and are the most common ones, and melanoma too, malignant melanoma. Yeah, those are the ones that are most common, but they are entering already into treatments for ovarian cancer, and the treatments for breast cancer and brain cancer. So it's entering into other areas also, which until now they were not very successful, but slowly the new clinical trials are making inroads there.
Thank you.
So let's talk about caregiving now. How is your organization that you're a part of helping the caregivers, and what kind of challenges do caregivers of cancer patients commonly face, and how do you address them?
Well, I think that caregivers are extremely important, and my main objective and my main recommendation is for a caregiver, especially those that suddenly have to be caregivers, that they would never knew about that, but suddenly because something happens in the family, and then they stand up and they say, okay, I will do I will help and do this and that. But they need to educate themselves. They need to learn about the disease of the person. They need to know about the possible symptoms. They need to learn about the treatment, not to go into nitty-gritty details, but enough to be able to have an understanding of the process and the side effects. That's extremely important. Once again, if the patients are having certain symptoms or side effects, and the caregiver needs to know how to identify them and how to even control them and how to treat them with the help of the doctors. So, and how to prevent them also. So you don't need to be a doctor, you don't need to be a psychologist, because what a cancer patient requires is support. It's helping them in dealing with a specific circumstance, a side effect or symptom. Being able to receive food or being able to see someone smiling at them, that is a lot. And it's a lot and means a lot for the patient, more than having a chat with the psychologist or the nutritionist, which helps. But education of the caregiver is of extreme importance. I know that the American Cancer Society runs the courses specifically for caregivers. I know in South Africa, Cancer
I was
Society.
a member.
Yeah.
It was very good.
Yeah.
Well, listen, let's take another break, and then we'll finish up with talking about geriatric cancer and their children. So don't go away. We'll be right back.
Okay.
We are a community of caregivers that understands and supports you wherever you are in your journey. We are a place to connect with other caregivers, but more importantly, a place to get practical, actionable help. There are lots of ways for you to get support. First of all, you can download our welcome pack. This will get you started on your Thrive journey. Next, you can ask and get answers to your questions by posting them here in our private Facebook groups. You can also get live online support by attending one of our live weekly Connect webinars. You can get practical, actionable advice by listening to our weekly podcast. You can hear and read other stories about other caregivers' experiences. Plus, add your own in our weekly Share Your Story forum, posted every Tuesday in the Facebook group. You can access essential resources and download practical Thrive Solutions packs, all of which are geared to help you thrive as a caregiver. You get lifetime access to all of our resources. Again, we're here to support you and help you thrive and to enjoy your life as a caregiver. And remember, this is a place to get hope, not just cope.
And we're back with Dr. Daniel Vorobiof and Adrienne Gruberg of the Caregiver Space. And doctor, let's talk about the cancers that are inherited. You know, doctors always say, "Does anyone in your family have cancer?" And if you do, then all of a sudden your insurance rates go up, and doctors want you to have tests more frequently. So, why is that?
Predisposition.
Thank you, Adrienne. I was looking for that word.
Let me say that, first of all, there is a little bit of a misunderstanding from that point of view, because cancers that happen in families, it's very, that the numbers of those patients is very small. It represents less than 5% of all cancers. So we ask, because what you just heard from Adrienne saying, that there is a predisposition. So it could be that along the line there is some gene that has been affected, once again mutated, and that can actually happen or can be carried by one of the persons in the family. That doesn't specifically mean that it's that every single individual in the family will have it, and that it will actually affect everyone.
Right.
So, for example, there are certain genes that we are more aware now. For one of them, it's called Braca Gene, that happens in some groups of people, mainly groups of clusters that there has been lots of intermarriage over the years, and I'm talking not over the last 10 years, but over the last 200 or 300 years, and one of them is Ashkenazi Jews, and because that was the way that they were living in congregations in Europe, in Russia, in the Arab countries, and they were living in close congregations. And probably because of intermarriage, these genes became carried from generation to generation. But not always they will induce a cancer. Nevertheless, we ask because of that predisposition. If a man had prostate cancer, the likelihood that the son will have prostate cancer at a certain age, it's higher than the normal population, but not higher that is 3 or 5 times more. It's just higher a few points and or decimal points. And but it's important to know. And the same with breast cancer, and the same with even with lung cancer in some instances.
Here's a real live example for you, doctor. Sorry for interrupting. But my brother, 6 years ago, when he was my age, had prostate cancer, and they used the little rice-sized marker to laser it, But unfortunately, it didn't go well because they missed the marker somehow and hit an artery. He almost bled to death. So a minor little surgery turned into a life and death situation. So I'm wondering, as they ask me my questions, as I'm now on Medicare, if anyone in my family has had cancer, and I think of my brother with his prostate cancer. So how does that predispose me? Because I'm his age now, and I just had a PSA, and it's very, very low.
Okay, well, that's good news. I cannot say that you have a higher possibility of having a cancer of the prostate, but
we have different lifestyles too. He drinks a lot and I don't, and I don't know if that matters.
Well, it could matter because alcohol is a carcinogenic, so it could matter. So there you have a good example where he could have that, but that doesn't mean that you will be having that. So like that, we have many, many examples. But that doesn't mean that there is a familiar cancer problem. It's someone in your family close to you has cancer, and but that person is influenced also by other environmental triggers,
right?
Which is different. Yeah.
Well, I can't believe how fast this hour has gone. Thank you so much for coming on the show. Is there any last-minute takeaway in the next 30 seconds or so that you can tell us that you may not have?
Just to inform the caregivers, to inform the patients that listen to this, about this great application that is there to help them at no cost and anonymously, so they shouldn't feel afraid of asking whatever question and whatever support they require. And we are there for them. And that's exactly the purpose of privacy.
I downloaded it already.
Yeah, privacy, like what happens in Vegas stays in Vegas, right?
That's right.
It's very simple to use. I mean, I've downloaded it while we're on the air. And
if Adrienne gives her seal of approval, it's good. Because she's pretty tough on that. She doesn't endorse anybody unless it passes the Adrienne test.
It's got to be easy to navigate. And
very good.
Fun.
So you can already start moving it in Manhattan.
There you go.
All right.
There you go. So again, the website is www.what for your
belong.life.
Belong.life. Instead of com, it's life. Belong.life. Some of those new cutesy suffixes.
The application is in the app.
In the app. It's an app store.
Oh, go to the App Store. Either the Google Play or the one on the Apple phone. Adrienne, how can our listeners get a hold of you to find out how amazing the caregiver space is?
It's the caregiver space it's very simple. It's the caregiverspace.org, and all of the social media links are on the website. And to get a hold of me, it's Adrienne, ADRIENNE, at thecaregiverspace.org.
And you actually have a cancer group there, right? In
Yes,
addition
we
to
do.
many other groups.
Yes.
All right. And my information is caregiverdave.com. That's where you can find everything about me and the shows and the videos and just anything you ever wanted to know. Go to caregiverdave.com. It's a membership site. You can join, and it's very inexpensive, one-time fee for the rest of your life, and you'll get like 6 years worth of content right there in one place. You'll never lose it or not know where it is. And Adrienne and Dr. Vorobiof, did I say that right? Vorobiof. There you go. I knew I had missed a syllable somewhere. And a reminder that this show and all our shows are live on our membership website and all 16 platforms. So thank you again, and we will see you next week. Bye-bye.
Bye-bye. Thank you, Dave. Thank you, Adrienne.
Thank you.
Thank you for listening to the Caregivers Caregiver radio program with Dave Nassani.